No questions from outside, so it's my pleasure to introduce to you Asma Khalil. She has recently published a guideline on twin pregnancy, which has been published on the White Journal. So there is no one who is more, let's say, entitled to speak about twin pregnancy, multiple pregnancy than she.
Well, thank you very much. It's a very kind introduction. So yes, we did the twin ISWG clinical standard on the role of ultrasound in twin pregnancy. It is published in the White Journal. I think it's free to download. Of course, I'm biased, but I think it's a good document, so I do recommend you to read it. And it has really a number of experts. So most of the experts in multiple pregnancy have been actually involved in this guideline, which I think is great. So what are the objectives? So what I'm going to cover over the next half an hour is dating of the pregnancy. Some of the stuff are quite basic, but actually you'd be amazed is the amount of medical legal work that we come across because of really not sticking to the basics, not actually getting the basics right in our practice. So actually, how do we date the pregnancy? What is the correct way of dating the pregnancy? Determining the chronicity and amnioticity, labeling of the twins, screening and diagnosis of aneuploidy, the discordant. So a large portion of my daily work is actually dealing with twin pregnancies that say that there is a discordance. And part of it is actually really diagnosing there's a problem in the pregnancy and trying to diagnose it early. But part of it is actually reassurance because majority of these pregnancies don't have problems. So discordance in size, discordance or the CRL, discordance in the nuchal translucency, discordance in anomalies or amniotic fluid. And then we get a touch on fetal reduction or selective termination and the TRAP sequence, which is really nowadays is a first trimester. It should be a first trimester diagnosis. And if we see it in the second trimester, it's because it was missed in the first trimester, or this woman did not have first trimester scan. And then lastly, conjoined twins, very rare condition that probably the majority of you, including myself, only see in very few cases. So it is true that we are seeing more multiple pregnancies. It's about 3% of the live births now is twins because we're getting older. By the time I get pregnant, I probably will have to have IVF, and then I will have twin pregnancy. It is a high-risk pregnancy, so certainly from both maternal and the fetal side. This is a diagram which I'm sure you're all familiar with about the different types of twin pregnancies according to the stage of the splitting of the embryos. Certainly more than 2/3 of your twin pregnancies are dichorionic diamniotic, which is the least risky type of twin pregnancy. But certainly as the splitting occurs at a later stage, the more the degree of the sharing in conjoined twins, which is extremely rare. Again, really basic fact, but just to get it right, all monochorionic twins are monozygotic. But not all dichorionic twins are dizygotic. So still, if you have a dichorionic diamniotic twin pregnancy, 1 out of 7 could actually be monozygotic. You'd be amazed that actually, maybe very few patients that actually know that. The majority of the patients, if it's dichorionic, they would say, oh, it's not identical, even if they have the same sex. So I think it's really important for us to know that, and maybe to actually convey this message to the patients. If you want to take one message from this talk, is the chronicity. It's crucial to get the chronicity right because this is what determines the risk in a twin pregnancy. It is probably the single most important risk factor of twin pregnancy is the chronicity. And you see here from these numbers that the risk of complications is higher in a monochorionic compared to dichorionic pregnancies. Not the zygosity. It is really what matters is the chronicity. How do we... This is a document that Katja alluded to. You can see the number of people that have been involved in this document, and it's required a lot of work, but I hope that it is useful. So, how do you date the twin pregnancy? You've got 2 CRLs. Which one would you choose to date the pregnancy? The smaller or the bigger? The bigger. Yes? The bigger if this is a spontaneous conception, but if it's an IVF pregnancy, you should use the IVF date So that either the oocyte, retrieval date, or the embryonic stage. And it sometimes can cause dilemmas and patient arguing if you still insist to use the bigger CRL and they have IVF dates. So if they have IVF dates, my advice is to stick with the IVF dates. If it's a spontaneous pregnancy, use the bigger CRL to date the pregnancy. When is the ideal time to determine the chronicity? Of course, in the first trimester before 13 weeks plus 6 days. And there are a number of signs that we rely on. Most important is the membrane thickness. So if you've got a thick membrane at the insertion with the placenta, it's a dichorionic. This is the lambda sign. And if it's thin, that's the T sign or the monochorionic pregnancy. Certainly, if you can rely on a number of placental masses. If you have 2 placentas, it's more likely to be dichorionic. But you just have to be really careful about that, about the number of placental masses. Because actually, a large proportion of dichorionic pregnancies is just the 2 placentas are adjacent to each other. So actually, you're really seeing 1 placenta. And on the other hand, certainly 3% of monochorionic twin pregnancies do show 2 placental masses on ultrasound scan. So don't rely on just one sign. And the evidence suggests that the more signs you look at, the more accurate you will be when you determine the chronicity. So, for example, if you see the 2 placentas and the discordant sex, and there is a thick membrane insertion or there's lambda sign, you're more likely to get it right. Yeah, so not just rely on one thing. Look at more than one sign. What the ISWAC document, and we had said that this discussion, it's an ISWAC. It's not a one country. It's not a UK. It's not a France. It's an international organization. So it has to reflect the fact that there is a degree of variation in our practice, in different countries. And because of the medical legal implications, it is what we really recommend is that you should have an ultrasound image of the chronicity in your records, whether that's in the patient's records or in your ultrasound records, something stored so that you can actually defend yourself and say, well, I said it was a dichorionic pregnancy because the fact I saw that. Yeah. What about actually if you can't? Suppose this woman is obese, and increasingly we're seeing more obese women. Suppose you actually do the scan, it's really difficult, or you can't or this woman have retroverted uterus, for example, and you can't be really 100% certain. The advice is to offer transvaginal scan. Okay, what about if you do transvaginal scan and it's still difficult? Advice is to seek a second opinion, maybe with someone more senior or maybe from a tertiary level. Suppose you can't. Suppose it's really difficult. Advice is to manage this pregnancy as a monochorionic, because you're more likely to see this woman more often and be looking or screening for complications. Yeah. What about the amnionicity? So a proportion of pregnancies that get referred to us as monochorionic, monoamniotic, actually they are MCDA. So if you can't see the membrane, please make efforts. So maybe do transvaginal scans to really be 100% certain that there is no a membrane. What about if you think it is and you can't see the membrane? What you need to do is to have a color Doppler and pulse Doppler and show that you have in the same, with the same time of gauge, you have 2 different heart rates. So definitely there are 2 babies in the same. The cord entanglement, which for years we thought that's why the monochorionic, monoamniotic twin pregnancies have increased risk of complications, or particularly of fetal loss, is actually quite almost a universal finding in monochorionic, monoamniotic twin pregnancies. In the first trimester, almost all MCMA twin pregnancies have cord entanglement. What about labeling? Well, again, it's really, really important to have an almost consistent, systematic way of labeling, and have it documented in the patient's notes. And the patient knows actually which is which, as well as you, because she might go and have a scan with someone else. So what we actually agreed, what we suggested is that you put as much information as possible to describe each twin. So, and I put an example here. So like, for example, twin A, the female, this is the baby's sex, on the maternal right with the posterior placenta and marginal cord insertion. That means if this woman had a scan today in London and next week she's in Berlin being scanned by Rabbi, he would know exactly which is twin 1. Yeah, so we are consistent. Have you heard about the perinatal switch phenomena? Okay, what we published is that in 20% of twin pregnancies that are born by cesarean section, actually twin A or twin 1 during the scan was born second. And is that important? Why I'm making fuss about it? Well, it is important, and I personally came across something like that, and you realize the importance of things when you come across them yourself. So it is really important when in a twin pregnancy that's discordant for anomaly that's not obvious by external examination. So, for example, one twin have hypoplastic left heart, and the other one is normal, and this woman have cesarean section, and the neonatologist, you told him that twin 1 is the baby that has hypoplastic left heart, and twin 2 is the one that's normal. But you actually delivered twin 2 first. So you give your neonatologist twin 2. And actually the neonatologist started obviously resuscitating and assessing the baby. Well, actually this is completely the normal baby. And then not realizing that the second baby is the one that has problem. Yeah? Another example is congenital diaphragmatic hernia, if one of the twins have that. So it's something that's not obvious by external examination. And if you're aware of this perinatal switch phenomena, at least you prepare your neonatologist and you have plan and measure in advance what you're going to do in order to identify which is which. How often do we or should we scan these pregnancies? For dichorionic twins, you've got the first trimester scan, and then after that, so you're 11 to 14 weeks, and then your anomaly scan at 20 weeks, and then every 4 weeks. That is uncomplicated twin pregnancy. Obviously, if they have complication, you might have to have more frequent scans. What about monochorionic twins? Well, what we agreed is that this is high-risk pregnancy with screening for complication. So you have your first trimester scan at 11 to 14 weeks, and then 16 weeks, and then after every 2 weeks for the rest of the pregnancy. Obviously, that might be an issue for some countries where maybe have significant impact on healthcare resources, but this is what would advise. Would advocate that would be the best thing. How about screening for Down syndrome? Well, certainly have multiple pregnancy or twin pregnancy have increased risk of having a baby with Down syndrome. And certainly the screening tests or the combined tests, for example, have higher false positive rate in twins compared to singleton, which means you're more likely to offer invasive testing in a twin pregnancy compared to singleton. But obviously, you have to discuss with the parents in advance the implications of discordant result. So if one baby have, say, Down syndrome and the other one does not have, because obviously there is a potential of selective reduction. Ideally, we should do screening for Down syndrome in the first trimester between 11 and 13 weeks plus 6 days. But it's really crucial that you have mapping of the fetal position. You know which is which. Because if you do the CVS and you have one baby with Down syndrome, and then a week or two later you're going back for selective reduction, you want to be absolutely 100% certain which is twin 1, which is the one that has abnormality. Particularly if there is no obvious fetal abnormalities on the scan. The other thing that's important to realize that in a monochorionic pregnancy, monochorionic twin pregnancy, you are actually giving risk per pregnancy because the two fetuses have the same karyotype. While in dichorionic or trichorionic pregnancies, you are actually giving risk per fetus rather than per pregnancy. So the advice is actually in Down syndrome, in twin pregnancies, we should offer combined tests in the first trimester. But if this woman does not have first trimester, or she turned up late, or you work in a place where you don't have the facilities, you can offer second trimester serum screening, but the performance, the accuracy of second trimester screening for Down syndrome is really low. And the other thing that you're giving risk per pregnancy rather than per fetus, even in a dichorionic twin pregnancy, which means if the risk comes back as high, you will have to do double invasive procedures. Yeah? What about in triplet? Well, we don't have serum screening in triplet pregnancy. So for triplet, you only use the maternal age and the nuchal translucency. to give the risk for Down syndrome. But we are in the era of NIBT, and NIBT in singleton is really, it is the most accurate screening test for Down syndrome, with a detection rate of 99% for Down syndrome and false positive rate of less than 0.1%. You can see this is the figures for the rest of the common trisomies. What about in twins? Well, it seems that it has similar performance to singleton, with a caveat. Number one, the number of studies that are published that did NIBT in twin pregnancies are far less than singleton. So we don't have the large number of cases that we have in singleton. The other thing is that it would be straightforward in a monochorionic twin pregnancy because it almost behaves as singleton, but actually in a dichorionic twin pregnancy, particularly if it's a discordant for anomaly or for trisomy 21, it can be much more problematic because of the fetal fraction. So certainly the suggestion is that in a twin pregnancy we should use a cutoff of 6% fetal fraction, while in singleton we're using 4%. So NIBT, very promising, but we have limited data compared to singleton. So this is back to the ISWAG document, and yes, we recommend that twin pregnancies should have the combined test, or if you don't have the serum screening, you should do maternal age and nuchal. If you have, in case of vanished twins, so you scan and you see there are two sacs, but one of them, the baby is much, much smaller. So you have a small embryonic ball. In this case, you cannot rely on a serum screening. You can just use a maternal age and then nuchal translucency. So which method of prenatal diagnosis we should use, amniocentesis or CVS? Well, it depends. Depends on the feasibility, on the accuracy, and the risk of miscarriage and embryo reduction. It's probably the most important is the fact that if you do CVS, it allows you early diagnosis, which means that if you would, or if the parents want to have selective termination or selective reduction, that you can do that in the first trimester rather than in the second trimester. And we know that selective termination have less risk if you do it in the first trimester compared to the second trimester. So certainly CVS is the preferred method in dichorionic twin pregnancies. What about if you have a monochorionic twin pregnancy with discordant anomaly? Despite the fact the majority of monochorionic twin pregnancies have the same karyotype, actually there are few case reports. There's a small chance of this heterokaryotypic twins, so they have different karyotype. And in this case, you might consider to do double amniocentesis, or at least amniocentesis of the abnormal twin. I mentioned earlier that selective termination is certainly better and safer in the first trimester, because the risk of miscarriage is about 7 to 8%, and the preterm birth less than 32 weeks is 14%. These figures are higher if you do the selective termination in the second trimester after 16 weeks. What about the discordance in the size? So discordance in the CRL. This was one of our papers from the Stork. This is a very large twin cohort in 10 hospitals in the southwest region. When we looked at actually what is the significance of having a discordance in the size, discordance in the CRL. Because we know that the discordance is associated with higher risk of fetal loss, abnormalities, or risk of fetal growth restriction or twin-to-twin transfusion syndrome. But is it actually predictive? And this is the ROC curves. This is a series of the ROC curves. You can see that all of them are not really predictive. So the CRL discordance is associated with the risk, but is poor predictor. It's not predictive of whether fetal loss less than 20 weeks, 24 weeks, perinatal mortality, discordance in size, or having a small twin. And that was the case both in monochorionic and in dichorionic twin pregnancies. But that's not the case if the discordance is early. So if the discordance in the embryo size between 7 and 10 weeks, it is actually highly predictive of the risk of fetal loss, single fetal loss. So that means if you scan a twin pregnancy at 8 weeks, and there is a big difference, one of the twins is much smaller than the other one, this pregnancy is high risk of death of the smaller baby. That means you ought to see this pregnancy again maybe in a week time. The detection rate was 74% for 5% false positive rate. Abnormalities, they are more common in twins compared to singletons. So if you have an incidence of abnormalities for around 2% in singleton, the incidence is double, so it's 4% in twins. That's 3% in dichorionic and 6% in monochorionic twin pregnancies. So what's the relationship between the CRL discordance and the risk of abnormality or aneuploidy? So you see, this is all these red dots are babies who had congenital abnormality. And you can see here, this is the CRL discordance. And you can see there's a huge overlap. So despite the fact we know that having a large CRL discordance is associated or increases your risk of the fact that one of the babies have abnormality or have aneuploidy, it's actually there's huge overlap. And the same applies for the nuchal. So here, if you have a CRL discordance of 20% or more, you have 6 times higher the risk that this pregnancy is affected by abnormality. And the same if you have one baby have increased nuchal of 3 millimeter or more, 6 times higher the risk that this pregnancy is affected by abnormality. Again, if you go back to the prediction, it's not really a good predictor. For a good prediction, you want area under the curve of around maybe 0.8, 0.9. It's only 0.6. So the CRL discordance cutoff of 10% have only a sensitivity of around 30% and specificity of around maybe 90% that this twin pregnancy have abnormality. So it is associated but not predictor. So what is the advice? Well, if you have a CRL discordance of 10% or more, or the nuchal translucency discordance of 20% or more, the advice is that this pregnancy should be seen by a fetal medicine expert, whether tertiary unit or yourself, whatever. And this pregnancy, you should consider offering invasive testing and doing karyotype or array CGH. What about the nuchal translucency? Well, if you have a discordance in the nuchal translucency of 20% or less, the risk of TTTS or fetal loss is very small. And this risk increases as the discordance of the nuchal translucency increase. So if you have, for example, here, if the discordance of 50% or more, you have very high risk of developing TTTS or fetal loss. What about the ductus venosus? Well, if you have reversed A wave in the ductus venosus, again, that increases the risk of miscarriage, twin-to-twin transfusion syndrome, and selective fetal constriction. How do you manage a twin pregnancy that's discordant for abnormality? Well, it's really tricky, and it depends on 2 important factors: the chorionicity of this twin pregnancy and the type of abnormality, whether it's lethal or not lethal. So, for example, if it is a dichorionic twin pregnancy with a condition that is lethal, perhaps maybe you don't want to intervene. You just want maybe conservative management, and the baby that has abnormality, trisomy 18 or anencephaly, will have expected management. Compared to a twin pregnancy that's discordant for Down syndrome or spina bifida, and it's a dichorionic twin pregnancy, where you would actually consider the option of selective termination. In a monochorionic twin pregnancy, it's a different story, because actually doing selective termination, you have to do it with cord occlusion. And the cord occlusion can only be done after 16 weeks. Can we do selective reduction in a monochorionic twin pregnancy before 16 weeks? Yes, we can, because you can do intrafetal laser ablation. So even you could do selective termination in a monochorionic twin pregnancy before 16 weeks. How do we do selective feticide? So in a dichorionic twin pregnancy, you will use KCL or lignocaine, and you can do that intra cardiac injection or injection in the umbilical cord. While actually in the monochorionic twin pregnancy, as I said, you have to do cord occlusion, or before 16 weeks you can do intrafetal laser. And again, as I mentioned earlier, if you would do selective termination, you would do it in the first trimester, because the risk of miscarriage and preterm delivery, if you do it 12 weeks, is much less than if you do it at 20 weeks. So the message, if you would do selective termination, ideally you want to do it in the first trimester, and that's why the preferred method for prenatal diagnosis in a twin pregnancy is CVS rather than amniocentesis. What about triplet pregnancy? What about the reduction in triplet pregnancy? Well, it is really important that if you have a triplet pregnancy that you have the discussion with the parents, whether they would opt for conservative management or reduction, but you really need to have this discussion. And I just summarize the discussion in literally 2 messages. It's really important to realize that reduction in triplet pregnancy does not improve the survival. It does not improve the survival. That's the evidence from the large studies and from systematic reviews. What it does, it reduces the chance of extreme prematurity and therefore reduces the chance of handicap. So the options really for triplet pregnancy is 3 options. Either you continue with the whole pregnancy, there's expectant management, you terminate the whole pregnancy, or you do embryo reduction. And the embryo reduction is either from 3 to 2 or from 3 to 1. How do you decide which baby or which fetus or which triplet you're going to terminate? Well, it depends on the scenario. So, for example, if you have all of them, all the 3 fetuses are normal, you did your anomaly scan, you did the nuchal translucency, you assess the risk of Down syndrome. In this case, and technically, you would go for the easier, either 2 or 3. So you try to avoid the one that's closest to the cervix. Okay, what about if actually 1 and 2 are monochorionic twin pregnancy, and this woman decided to do reduction from 3 to 2? In this case, you would go for number 3 and maybe continue with the monochorionic twin pregnancy, knowing that you still have increased risk of twin-to-twin transfusion syndrome and all the complications of monochorionicity. What about if actually twin 1 is anencephalic and this woman decided to have selective reduction? So that would be okay, that would be straightforward. So you would terminate the twin or the triplet that is anencephalic, but knowing that the risk of miscarriage might be slightly higher because you're actually doing reduction of that triplet that's closest to the cervix, or the lowest one. What about if triplet 2 and 3 have increased nuchal translucency? Well, it depends whether you want to do CVS first or you want to do prenatal diagnosis first to exclude aneuploidy before you undergo reduction. So it's really important. In the past, reduction used to be done early, so maybe before even 11 weeks. But nowadays it's really important that you actually have the 11 or 12 week scan, because you assess the risk, you measure the nuchal, you look for the abnormalities before you decide which triplet you're going to reduce. The worst thing is that you reduce, if you have triplets and 2 of them have abnormalities, for example, and you reduce the one that's normal and you left the 2 that's abnormal. So it's better to wait until 11, 12 weeks, do proper assessment of the 3 babies before you have the discussion of the reduction and which fetus you would reduce. What about the discordance of the amniotic fluid? So sometimes you scan someone in the first trimester and you actually say, okay, well, the CRL, there's not like big discordance, but there is amniotic fluid discordance. And is this pregnancy have increased risk of developing twin-to-twin transfusion syndrome, for example? And if you look at the data that's published, amniotic fluid discordance, yes, it does increase your risk, or is associated with the risk of developing twin-to-twin transfusion syndrome, but actually the majority of these pregnancies do not develop twin-to-twin transfusion syndrome, and the outcome of the survival is 93%. Yeah, so it's a very low risk of progression. But the problem, you can't predict that in the first trimester, so you still have to see this pregnancy almost every week to see whether this discordance in the amniotic fluid will actually eventually develop twin-to-twin transfusion syndrome, or it might remain the same, or even might regress. So the discordance that you saw it in the first trimester might actually disappear, and the amniotic fluid might become normal in the two sacs. What about TRAP? Well, the TRAP is twin reversed arterial perfusion, when one of the twins is actually almost giving the blood supply to the other one. So why is it important? What are the risks of this twin pregnancy? Well, the risk is that there is an extra load on the pump twin. So the risk of fetal demise of this twin. But the other thing as well is that this twin might develop polyhydramnios, and the whole pregnancy have very high risk of preterm birth, preterm delivery. Okay, well, if there are risks, why don't we just treat it in the first trimester? Well, the argument again is that actually a proportion of this pregnancies, if you don't do anything, there will be a spontaneous cessation of the blood flow in the trap mass. So just by conservative management, it might be the blood flow might stop by itself. The problem while waiting for potentially this blood flow to spontaneously stop, it actually is a high loss rate. It's about 50% of his pregnancies. So you do the assessment at 12 weeks, you diagnose a trap, and the bump twin is okay. So you say, fine, I'm going to see you again at 16 weeks. Potentially there's three scenarios. Number one is actually the blood flow stop in the trap mass, or actually the bump twin demise, the bump twin dies, or the patient comes back and still you've got this reverse flow in the trap mass. There are many studies that actually reported on prenatal intervention, where you actually stop the blood flow in the trap mass. And you can do that a number of methods. You can do that in the first trimester with the intrafetal laser ablation, or you can do that later with fetoscopic cord occlusion. And most of them quoted 80% survival rate and low risk of preterm birth. So certainly, there is a feeling that early intervention in these cases is probably have better survival, improve the survival, and have less risk of preterm birth. So this is the study that I showed you. So this is from Lisbeth Louis and Kibros, where these trap masses that were seen at 12 weeks, and then when they come back at 16 weeks, already about half of them, the bump twin died. There is a high loss rate while you're waiting for this spontaneous cessation of the blood flow in a trap mass. So this was a meta-analysis that we published, where we looked at actually doing intrafetal laser treatment for the trap mass, and we found that if you don't do anything, if you just wait between the first trimester and the second trimester, there's a high loss. A large proportion of the pump twin would die. If you actually do interfere and do the laser, the survival rate was 80%, with a low risk of adverse outcome, particularly the preterm birth, which is one that you are most concerned about. And this is the results of the meta-analysis. And that was the recommendation from the ACEWAC document, is the fact that that we should actually consider early intervention based on the evidence. Despite the evidence is not from randomized controlled trials, it's still observational, but it seems that it's quite convincing that probably early intervention in these pregnancies have better outcome. This is a trial called TRAPPIST, which is about to start, which is a randomized controlled trial of early versus late intervention in trap cases. So this case is seen at 12 weeks, 12 to 14 weeks, and then either we'll have the early intervention or we'll wait until 16 weeks and have the late intervention. My last slide is about the conjoined twins, and I said it's extremely rare. It's quite complex, and I just summarize really what the key messages or what I would do if I see a case with conjoined twins. There are different classification and probably the simplest one, is to divide the twin according to the site of union. So is it ventral union, lateral, or dorsal? And what I would suggest is that if you see a case like that, just describe what you see. Describe that the twins is fused at this position, and what organs they are sharing. It's really, really important to look at the associated abnormalities, because there's very high risk. About 50% of conjoined twins will have associated abnormalities. The commonest is a congenital heart abnormality. So certainly these pregnancies, if they continue, they need to be seen by a cardiologist. Other abnormalities like neural tube defect or midline fusion defects or orofacial clefts and perforate anus, congenital diaphragmatic hernia, and polyhydramnios. So the very high risk of associated abnormalities, and the prognosis is dismal. Very high rate of stillbirth, neonatal deaths, and preterm birth. So at least in the UK, the majority of these pregnancies will opt for termination, particularly that the diagnosis nowadays is usually done in the first trimester. But certainly for those who continue the pregnancy, the prognosis would depend on what type of conjoined twins, what organs they're sharing, and associated abnormalities. So really my take-home message, or the most important message from this talk, is about the chronicity. You need to get the chronicity right, because this is what would determine the outcome and the management of the pregnancy. Thank you.
Thank you very much. Are there questions for Asma? Well, I have a question for you. Suppose that you have a dichorionic triplet. How would you counsel the patient? And then I will ask you something else.
Okay. So for a dichorionic triplet, number one, the risk of preterm birth. So the risk of preterm birth less than 32 weeks, which is the preterm birth that really matters, because associated with high risk of perinatal mortality and morbidity, is about 30%. So 1 in 3 of these pregnancies will deliver before 32 weeks. The other thing, because it's a dichorionic, so two of the babies are sharing one placenta, there's increased risk of twin-to-twin transfusion syndrome, and the risk is around 20%. In a dichorionic twin pregnancies, about 20% there's risk of developing twin-to-twin transfusion syndrome.
Okay, careful because... And if the patient would want to do a selective termination, which of the two pregnancies would you advise to terminate?
Okay, this is really tricky, because you could just go for the singleton and keep the twins, which is going to be a monochorionic twin pregnancy. So you still have the risk of twin-to-twin transfusion syndrome. You still have all the risk of monochorionicity. Or you should go for the monochorionic pair and continue the pregnancy as singleton. And that would be my preferred option if it was me, because that would reduce the risk of preterm birth dramatically. So yes, the risk of miscarriage, the initial related to the procedure from 3 to 1 might be slightly higher, so maybe 10 to 15% risk of miscarriage from 3 to 1, but that means that you reduce the risk of preterm birth dramatically, and then you don't have the risk of twin-to-twin transfusion syndrome anymore, or the risk of monochorionicity. There is the option of actually doing the intrafetal laser, which means that you convert the dichorionic triplet into a dichorionic twin pregnancy. The only problem is that this is really limited experience. There's only a small number of cases that are published, and there's some experts in the field have raised concern about maybe the risk of neurological disorders secondary to your intervention in the first trimester. It's difficult really to say whether there is a risk or not. The few case reports published, but they have good outcome. That's from Cyprus.
And you are now very much up to date with the recent literature. Is it true that there seems to be an increased chance in developing TTS if you, in such a situation, spare the monochorionic twins?
Well, I don't think there is evidence that they compared, for example, a dichorionic triplet that didn't have reduction compared to a dichorionic triplet that had reduction and continued with a monochorionic pair, and whether the risk of TTTS has increased. But certainly there is a risk of TTTS in about 20%, which I think is high. 20%. It's higher than a monochorionic in MCDA, where the risk is about 10 to 15%.
So it is higher. It is higher. Rabi?
Do you see me? No. You were saying that half of the fetuses with a trap sequence, one will have the cessation of blood and the other one will be developing normal. Yeah. But this is similar to the spontaneous deaths in twin-twin transfusion. Do you have any evidence of brain damage of the co-twin in these cases, or if it's occurring early, it doesn't happen? Or we had a case. This is why I'm asking you about it.
Yes. So, so the cases that we published. So this is cases that had intrafetal laser in the first trimester. We were publishing this paper. So we contacted all these moms to see how the babies are doing, and none of them have sort of any obvious evidence of neurological handicap. There is no paper, to the best of my knowledge, that looked at the neurological outcome of these babies. The TRAPPIST, the trial that we are going to start, will have 2-year follow-up of these babies. So 2-year neurological outcome will be for the 2 arms. So the arm where you have the delayed intervention, or the arm where you have the intervention in the first trimester.
But the one having spontaneous cessation?
I'm not aware that there is any problem with them. They seem to be fine, I think. Or at least there's nothing in the literature to suggest that they do have a problem.
Okay.
Okay, thank you.
We have